So here we have it. So why don't we go ahead and introduce our esteemed guests this evening. So we have both from the Riverside County Department of Public Health, Kim Saruwatari, and Dr. Geoffrey Leung, the Public Health Officer. So welcome, Saruwatari and Dr. Leung. Thank you so much for joining us. I know you must be insanely busy, so we really appreciate you taking the time out to speak to the community again, because I know it's been a few months since we had our last update. So without further ado, let me share my screen and bring up the presentation. And
thank you, Jeff, and thank you for having us. We always enjoy the conversation with this group, and I think this might be the first time that you all have met Dr. Leung, our new public health officer. So I have no doubt that you will enjoy him, and he brings a great perspective and lots of experience to the table. So in fact, maybe what we could do is, Dr. Leung, do you want to just give a quick kind of background about yourself so folks know a little bit about your history?
Sure. Thank you, Kim. So I apologize for the background noise. I'm running late, so I'm supposed to be 30 miles, but my background is as a family physician, you know, and before serving in this role, I was serving as the medical director for the clinic for the county hospital, as well as the county federally qualified health centers, which are primary care clinics, and you know, have been fortunate enough to be part of Riverside County since 2006. I've worked at a number of different sites and also helped to train family medicine residents at one point, but am truly blessed to be able to work with the team in public health and with the county. And you know, it's been a really difficult time with the pandemic, but I think there's also been a silver lining. And you know, part of that silver lining is just you know, seeing what an incredible community we have. So you know, really appreciate having a chance to be part of this discussion this evening. Thank you.
Great, thank you, Dr. Leung. And just because I'm really excited about it, I just want to tell you about a couple other staff additions that maybe you will have the opportunity to interact with. So one of the things that became incredibly painfully obvious is the fact that having one public health officer is not enough, particularly during a pandemic, right? When our poor public health officer is pulled in 50 million different directions. And so we were able to secure approvals from the county executive officer, and we hired 2 deputy public health officers to back Dr. Leung up. So hopefully at one of the future meetings, maybe we can have them join and you can get to know them. Both are amazing individuals. One, Dr. Jennifer Shavinsky, is actually from the area. She did her training at Loma Linda, and then she went back to the CDC and was in the Epidemic Intelligence Service and traveled around during the COVID response to various locations, and has done a lot of research on long COVID. And so she might even be able to come back and talk about that to the group. That might be of interest. And then the other one is Dr. Sang, and Dr. Sang actually also has worked for WHO, CDC, but has spent a lot of time working in our community health centers at the county, and just has an incredible background and desire to serve her patients. And she's just a wonderful person. So I'm sure that you will enjoy both of them as you get to know them. And then the third one that I just want to mention is we also hired Dr. Marshar Penny. She is a DRPH, not a physician, but Marshar comes to us. She worked for the health department and then got her DRPH and went to work at Cal Baptist, and actually was in charge of their public health program there. And then we stole her back. And so now she actually is in charge of our equity and diversity program. So we're super excited to have a very focused mindset around equity, and making sure that we think about equity in all of our programs and everything we do. So I think lots of great things happening at the health department, even while we're in the middle of a pandemic. So just wanted to share that with you all. And I guess we can jump right into some of the information we wanted to share with you, and feel free to stop us and ask questions, or we can do it at the end, whatever you prefer, Jeff.
I think, yeah, people could raise their hand or type questions in the chat, and I can ask them during real time, and then we'll have, open it up for free
Perfect.
for questions at the end.
Okay, perfect. All right. If you wouldn't mind going to the next slide for us, Jeff, thank you. And so we have kind of a list of things that we wanted to talk about today, just give you an update on the numbers. I'm sure that nothing we say will be a surprise to you all because the news is reporting what's going on in fairly real time. But then we'll talk, Dr. Leung will talk a lot about the additional vaccine dose guidelines for folks that are immunocompromised, masking and social distancing recommendations, and then also just a little bit about variant surveillance in Riverside County, what we're seeing and what we're not seeing. So we'll quickly touch on those topics. Next slide, please. And Dr. Leung, do you want me to start or do you want to start? If you're driving, I don't want you reading.
You know what? Why don't I start with the masking and then maybe I can pass it off to you for the numbers.
You got it.
Okay. So thank you, Kim. So, one of the topics we saw that there might be some interest in is regarding masking and social distancing. And this has been a really confusing topic because there have been so many changes over the past year. So we did just try to summarize, sort of give you the Cliff's Notes or the cheat sheet on all the changes that have happened. And really in terms of masking, that's the way we prevent transmission right now of COVID, although vaccination is kind of the long-term solution. And right now there are actually several settings in which masks are always required of everyone, even if you've been fully vaccinated. So that includes places like public transportation sites, buses, schools, for instance, kindergarten through 12th grade, child care centers, shelters, correctional facilities, skilled nursing facilities, and healthcare settings like clinics and hospitals. So again, everyone in those settings has to wear a mask. There's not really any pass for that. Then next of all, in California, everybody who is unvaccinated who goes to a public setting, and that might include public indoor settings such as a movie theater or a restaurant or a mall or a shopping center indoors, all unvaccinated people are supposed to be wearing masks. Now, that's difficult to monitor because we can't tell who's vaccinated or not, but that's actually required in California. And then finally, all workers in California who are unvaccinated also required to wear a mask, and that's through Cal OSHA, or a different sort of set of rules and guidelines. So there are actually many settings in which masks are required, and they're always required of unvaccinated individuals in indoor settings. And on top of that, California Department of Public Health has recommended that even people who are vaccinated should ideally wear a mask indoors, and that's because of the Delta variant, which we found to be more contagious. In terms of social distancing, overall, there are largely no longer social distancing requirements. And the capacity requirements, where we used to say that you could have this many people in a restaurant or this many people in a movie theater, those things have all, by and large, gone away because we now have two very effective tools with masks and vaccination. And maybe, Kim, I can pass it back to you.
Great, thank you. Jeff, if you wouldn't mind pushing us forward another slide, please. All right. So just some quick updates on the data, and these are data as of the 3rd. The staff took a little bit of a break over the weekend because they don't get to do that very often. So our case rate in Riverside County, we're close to 33%. You'll see from the slide, it says we are decreasing. We got up as high as about 35% in this wave of positive cases. And so although it is decreasing, it is still way too high. So it's something that we're monitoring very closely and want to see that number continue to drop. We are above the state's case rate, which is at about 28.4 per 100,000. Our positivity rate also has been decreasing over the last week or so. It was up as high as about 11%. We're now down to 9.5%. And when I say it was up as high as 11, that was just during this surge. It was much higher during the winter surge. But still, that is still too high, and we need to get that positivity back. It was down less than 2% It was at less than 2% when we were at our lowest. So we need to get it back in that kind of a range or lower, preferably. Our testing rate has quadrupled in the last month or so. So we're seeing a lot more people wanting to get tested. We think that has to do with the spread of the Delta variant, and then also all of these testing requirements that are in certain sectors where they have to test their employees or students. So we were down sitting at around 100 tests per 100,000, and we're now, over 465 per 100,000. Are hospitalized. There was an article in I believe it was the Desert Sun, about Riverside County having the second highest number of hospitalized cases. And so we are at 673 hospitalized cases. And we have dropped, actually, we have about 62 of them have been discharged over the last few days. And so we are seeing that number go down as well, which is a positive sign. And we hope that that continues. We do know that our hospitals are running at about 85% census. And a lot of that is due to conditions other than COVID. And then the other thing I just wanted to mention, particularly to this group, when we are getting data on hospitalized individuals, it is not a perfect number, because we know that there are people who are in the hospital for other reasons that are getting tested for COVID and testing positive. So they aren't necessarily hospitalized for COVID. They are in the hospital and have tested positive for COVID. So we are trying to drill down on those numbers, but as you can imagine, for those of you that work in a healthcare facility, when you're in the middle of a surge and taking care of patients, it's challenging to kind of get a lot of real-time accurate data. And so that's something that we're still working through with the hospitals. Our vaccination numbers, 12 and older, we are partially vaccinated, we're at about 62.8%, and fully vaccinated 12 and older, we're at 54.2%. So the numbers continue to creep up incrementally, but we definitely need to get that 54.2% number up so that we can have some of the benefits of herd immunity and really some protection in our population. And many of you may have heard Dr. Frieden, who used to be the director of the CDC, talk about the Delta variant being kind of a heat-seeking missile, and that it is looking for individuals who are unvaccinated, and it will find them and make them sick. So, we really want to make sure that our population is protected. Vaccination, the best way to do that. And then, of course, masking and other protective factors. Next slide, please. Thank you. So our effective is a measure that looks at, basically it's a measure of transmission in the community. So for every person that is infected, how many people will they infect? And in order to get a pandemic under control, your R effective needs to be less than 1, meaning that you will spread to less than 1 other person if you are infected. So Riverside County right now, we are sitting at just below 0.9 for our R effective. So that is good. It's good news. It means that the spread is slowing. But it is something that we watch because there's quite a bit of fluctuation in these numbers. And if we pop back up over 1, then that means that we are starting to increase our spread. So something that we monitor, these are data actually from the state. They do some modeling. And so this is a modeling of R effective in Riverside County. Next slide, please. Let's see. Dr. Leung, do you want to take this one on forecasting?
Yeah. So there's a lot of fine print on there, but if you look at the dark curve, on the left side of the dotted line is a black curve with dots, and the top one tells you how many COVID hospitalizations we've had in Riverside County up to present, which is the dotted line. And then on the right side of that shows the prediction for how many COVID hospitalizations we think we'll have during the next month. And so you can see that that number is falling, which is a very good sign. And then below that is a curve showing the recent ICU cases that are related to COVID or for patients with COVID. And again, in black is what we've had in actual cases up until the dotted line, the dotted vertical line, which is present, and then sort of everything to the right is what we're predicted to be for the future. So both the COVID hospitalizations and COVID ICU cases are predicted to be lower 1 month from now than right now, and that is because, you know, we think you know, the R effective is less than 1, and we're trending in the correct direction. So maybe Kim, I'll pass it back to you.
Sure. Next slide, Jeff, please. All right. Some of you may have already seen this. This is data that we recently presented at our Board of Supervisors meeting. These are just numbers looking at our own caseload and our own data in Riverside County. So we tried to kind of depict boxes and show how small the number of people that have that have been vaccinated and then develop COVID after they are fully vaccinated. So if you look at the big box on the left, this was at the time when we put this slide together, which it's a few weeks old now, there were just over a million people vaccinated. And of those, there were 3,761 cases among our fully vaccinated population. So less than at 0.35% of our total vaccinated population went on to develop COVID or have what some people call a breakthrough case. Of those, we did have 23 deaths. But again, of all of those individuals that were vaccinated, that's 0.002% of everybody who was vaccinated. On the
question, if I may.
Yeah,
so
please.
When you say COVID, they got COVID, does that mean they had a positive test? Did they actually have symptoms?
They had a positive test and they had to meet our case definition. So it was more than 2 weeks past the second vaccination or the first if it was J&J. And then they had to have not had COVID in the 90 days prior so that it wouldn't be an old infection that was being picked up again.
Thank you.
Yes, of course. And then on the converse side, if you look at the blue box, unvaccinated individuals, we have about 830,000 roughly. Among those folks, we had about almost 110,000 cases. So about 13.2% of the unvaccinated people in the county have become infected with COVID, and about 2,148 or 0.3% of those have died. So you can see the risk of getting COVID and dying from COVID is much greater among the unvaccinated population. So, you know, according to our data, about 37 times more likely to get COVID than if you're unvaccinated than if you're vaccinated. Statewide, where they have, you know, greater number of data points to look at, they find that to be about 10 times higher risk, somewhere between 10 and 15 times higher risk if you're unvaccinated than if you're vaccinated. According to our data, you're 120 times more likely to die from COVID if you are unvaccinated compared to those who are fully vaccinated. So these are data that we get asked for all of the time, really wanting to look at the comparison of vaccinated versus unvaccinated. And this is really when I get asked questions about, is the vaccine safe? Should I get vaccinated? These are the types of data that are helpful in telling that story, that yes, being vaccinated really protects you from getting infected, from getting hospitalized, and from dying. And if you do get infected with COVID, it's usually a very mild case. So next slide, please, Jeff. All right, so these are our numbers of cases among our Riverside County residents, and this is looking between February and August. So if you look early on in the pandemic or in the pandemic when we had vaccine available, so starting in like February, you'll see that the number of cases among vaccinated individuals is very low, 0.3%, and it has increased pretty steadily. So in July, we were at 17%. We've had an increase in the number of vaccinated individuals. And so because more people are vaccinated, you would anticipate that our number of cases among the vaccinated population is going to increase. If we get up to 80, 90% vaccinated, fingers crossed, then the majority of our cases would occur in vaccinated individuals, right? But even still, even when we're at 17%, that means that 83% of those cases were in unvaccinated or partially vaccinated individuals. Next slide, please. Dr. Leung, do you want to talk about this one?
Sure. So, what you see are kind of month to month, the number of COVID hospitalizations occurring in either vaccinated individuals in red or unvaccinated individuals in sort of that gray blue. And you can see that the vast majority of COVID hospitalizations are happening in the unvaccinated group, and that it's actually remained fairly steady over the past several weeks. So in general, we're seeing about 8 to 12% of all the COVID hospitalizations happening in people who've been previously vaccinated. And then about, 88 to 92% are happening in people who have not been vaccinated. So that's been pretty steady. The cases that are happening in the unvaccinated the cases that are happening in the fully vaccinated hospitalized patients are generally also happening in people who tend to have more medical problems and who may be older. So that's a caveat as well. And I think we can go to the next slide, and maybe I'll pass it back to Kim.
I thought I was going to get through without talking with my mute button on. Sorry about that. Okay, so the other question that has come up consistently in conversations that we're having or when we're talking with groups is what's happening among our kids, right? Because nationwide, we know that the number of cases is up in children. And so we took a look. And so if we look just at our 12 to 17-year-olds, and the reason I would focus there is because we know that they're eligible for vaccination, right? So our unvaccinated 12 to 17-year-olds, we've had 7,348 cases in that group versus our fully vaccinated, only about 60 cases in our 12 to 17-year-olds that are fully vaccinated. So again, that's running about 96 or 97% of the cases are occurring in unvaccinated individuals and kids. And if you just look at the last couple of months, very similar, we've had about 2,061 cases in kids 12 to 17, and about 59 of those have actually occurred in people that are vaccinated. So the numbers are very small in the vaccinated versus the unvaccinated. And so we continue to recommend that parents get their kids vaccinated. It's the most protective thing that they can do. And we are all anxiously awaiting for vaccination approval for kids 5 to 11, and hopefully not too long after that, under 5, so that we can get some protection in that younger age group as well. Next slide, please. Dr. Leung, do you want to take this?
Sure. So, one of the questions we know is about the additional vaccine dose that has been recommended for immunocompromised individuals. So we the main reason for this is in studies, they found that people who may be on cancer treatment, people who've maybe had a stem cell transplant, people whose systems are not kind of fully working and fighting off infection, they did not develop a full immune response after they got the full series of the vaccine dose. And in fact, immunocompromised individuals, even when vaccinated, have a much higher risk for ending up in the hospital or having serious complications. Now, this is only a very small portion of the adult population, so we're talking about less than 3% of all adults. But it's serious enough where the CDC said, for this specific group of individuals where we know they have a higher risk for hospitalization, even though they've gotten their full series of vaccine, we're going to recommend an additional dose. So sorry, next slide, please. So they actually outlined a few groups. And again, they said that people who are moderately to severely immunocompromised include individuals such as those getting active cancer treatment, those who have had an organ transplant, maybe a kidney transplant, and they're taking medicines for that, people who've had a stem cell transplant, or who might have a primary immunodeficiency, meaning that their body has trouble fighting off infections, or those really pertinent to our discussion today, who may have advanced or untreated HIV HIV infection. And finally, people who might be taking immunosuppressive medications like high-dose corticosteroids. So all of those individuals, we would recommend at this point today a third dose of Pfizer or a third dose of Moderna vaccine.
This is Jeff with another clarifying question. Can you define for us what advanced HIV infection means?
Yeah, so this, we're hoping this really becomes a definition of the past. Advanced or untreated HIV typically would be someone who has not gotten any antiretroviral therapy, either completely or has been off medication for probably at least a year or longer. And really our hope is that, people that we know would not fall into this category. So it should be a very uncommon occurrence. Now that being said, a common question we might receive is, I might have HIV, but I might be getting my treatment. So do I fall into this group? If your doctor says that they think you need to get the additional vaccine dose, then you should get it. And it's by there is not a proof or a threshold or a doctor's note that you need to bring to get that additional vaccine dose. But again, that being said, if people are taking their medicines and they're doing well, even if I have HIV, I may actually be in a group that would not be considered to be moderately to severely immunocompromised. And so if I'm sort of in that general population, we actually have not received official guidance on that booster for the general population yet. So great question.
Jeff, I have a question.
Yes, go ahead.
Jeff, I read recently that the Moderna third shot has not been approved yet. Is that true? Or has it been approved?
So this is a confusing question. So first of all, for the additional vaccine dose for moderately to severely immunocompromised individuals, we do have a recommendation from the CDC to give either a third dose of Moderna or a third dose of Pfizer if people receive that vaccine series before. They base this recommendation off of Pfizer data. But because the two vaccines are very similar, they made the recommendation for both. Now, what's even more confusing is when we're talking about the booster for the general population. So people who don't fit one of these categories, neither Pfizer nor Moderna has been approved for that booster for the general population. So I'm not sure if that makes sense, but the languaging is very confusing.
Thank you.
I see another question from Jerry. Go ahead, Jerry. You need to unmute.
Okay. Can
There
you
you
hear
go.
me? Yeah. Can you hear me?
Yes, go ahead.
Okay, thank you. Have any studies anticipated to find out if HIV people were the vaccines for them were less effective? And a related question, have you studied that as a separate group in terms of getting infected after the vaccine among HIV people?
So that's a great question. I have not personally seen studies that have focused on HIV individuals in terms of vaccine efficacy. We do know that we're starting to get studies looking at COVID infections and what happens during the normal course of sort of recovery, but those in HIV individuals, but that is just starting. And so I don't know if anybody else on the call or the meeting has additional information, but I haven't seen anything yet on that.
This is Jeff. It's kind of all over the map, but I did see something in the last few days from South Africa that suggested that the efficacy rates were about the same in both positive and negative in South Africa.
Can you repeat that, Jeff? I couldn't hear you too well.
Sorry. I did see a study in the last few days from South Africa looking at both HIV positive and HIV negative people. And those data suggested that the vaccine worked equally but well in both populations.
Yeah, great.
But I think, as Dr. Leung said earlier, people with HIV have lots of other comorbidities, other, immune compromised conditions besides their HIV. So that can put them at greater risk, independent of their HIV. There is another question from Deanne. She said that my understanding is that arthritis medications such as Enbrel and others are immune suppressants, but to what degree? Mild or great, or do we know?
Yeah, so that is a good reason for a conversation with your doctor. And you're absolutely right. Some of these very advanced and very effective medications for things like rheumatoid arthritis can suppress the immune system. So if you're not sure, talk with your doctor, and they may very well recommend an additional vaccine dose.
Great. Thank you for indulging us those questions, but obviously this is the slide where all those things come up, right? So thank you. And if anybody has anything else, put it in the chat, or we'll get them at the end. Yeah, and I guess that's the last bullet point, right? Active treatment with high-dose corticosteroids or other immune suppressive drugs. You ready for the next slide then?
Yes, please.
Yeah.
And maybe we can pass it back to Kim. And I think she also added something in the chat too.
I did. Thank you, Dr. Leung. I just put the Infectious Disease Society of America recently came out with a document. So it has questions and answers about COVID-19 vaccines in persons living with HIV. So that's the link to that. So that has some information on efficacy, and it says exactly what you were saying, Jeff, about finding that the similar response in vaccine efficacy. So. All right, so we also are looking at variants. So lots of data, lots of discussion in the news about variants and what's happening in the variants around the country. So you may recall back in early summer, we started to see the Delta variant increase. And in California in June, the Delta variant was making up maybe 30 to 40% of the specimens that were tested. Now it is at about 96 or 97% of the specimens that are tested. But I will qualify that with only less than 10% of all of the specimens that are collected in the state of California are actually sequenced. Sorry, that is my son getting ready for baseball practice and getting his water bottle ready. So I apologize for the background noise. So only a very small percentage of the specimens are actually submitted for whole genome sequencing.
Could you repeat that? I couldn't hear. Can you go a little slower?
Sure,
please?
absolutely. So in California, only about 10% of the specimens that are collected for COVID testing are actually sent to labs for whole genome sequencing. So the results that we share with you are based on a sampling of about 10%. And so of those 10% that are collected, about 97% of them now are Delta variant. So Delta is absolutely far and away the predominant variant that we have in the state of California, and in the United States in general. In Riverside County, we have similar data. So you can see from this chart, we have about 371 Delta variants, but I will say we are wholly reliant on whole genome sequencing by the state of California. So a very small percentage of our specimens are tested, less than 10%. I would say we're probably on the magnitude of 2 to 3%. Dr. Leung, if you think differently, please chime in. So very small percentage of our specimens are actually submitted for whole genome sequencing. Given that, though, we still presume that the vast majority of them are Delta, based on the characteristics and what we're seeing in terms of transmission and who's being impacted. It's consistent with what's being seen statewide and nationwide. There has been some talk lately about the Mu variant. LA County's reporting that they've detected just under 200 of the Mu variant. There is some concern with that particular variant because it may be even more transmissible than Delta and may have some additional resistance to both vaccine and monoclonal antibody. Although I think that more investigation is still needed on both of those fronts. So I think in general, the important thing to remember with variants and what we try to impress upon the general population is that if people get vaccinated and we can get a high level of vaccination, there's less opportunity for the virus to mutate. If we still have a large population of susceptible individuals, then that's just a vessel for mutations to occur in the virus. And we run the risk of seeing variants that are going to be more transmissible, more resistant to vaccine, and all of those things that we don't want to happen. And I think we have one more slide, Jeff. Oh, just our contact information. Dr. Leung, anything you wanted to add to the variant piece there?
I don't.
Okay.
Thank you.
Okay.
So there's some questions that have been posted. Someone asked about booster shots for those who got the J&J vaccine. Any word on that?
So we are still waiting for guidance on the Johnson & Johnson, and the CDC and the FDA know that there are many anxious people waiting to hear about that.
Stay tuned, okay. And then Alex asks, what factors are driving the current and projected declines in transmissions and hospitalizations, I guess, especially in light of the variants of concerns that you're just talking about?
So, you know, and maybe Kim, you can jump in as well. You know, we'd like to think that a good part of the declines are related to the increasing vaccination rates. Another thing that we see, though, is as hospitalizations go up and more people get sick, people also tend to be more cautious. So there's sort of you know, a balancing effect with behavior. So people are probably better with masking and distancing and staying away from groups when they see that more people are getting sick around them. So it's probably a combination. And I don't know, Kim, if you have anything to add there.
Yeah, I think you're spot on, Dr. Leung.
And somebody asked about where things are with a third booster for other populations. Do we know when those recommendations are expected to come out?
So I think this is what everybody's speculating about. And if you've been following the media, then you've seen and heard every version that you could imagine. You know, right now from the Biden administration, you know, they are clearly hopeful that we will be able to get a booster out for the general population around the week of September 20th. However, you know, they've also been cautious to say that in order for that to happen, both the FDA and the CDC have to approve and authorize, you know, the booster for this purpose. So the FDA does have a meeting scheduled on September 17th where they will be looking at the data. And last week, actually, the CDC had a pre-meeting, and their advisory committee on immunization practices did share that they felt like based on the data they saw last week, they might be able to make a recommendation for the booster for limited groups, such as those staying in long-term care facilities or healthcare workers, but they weren't actually sure that they could make a recommendation beyond that based on the data. So there's also a little bit of a waiting game in terms of data. And I think there is a hope that if they can wait a little bit longer, they'll have enough data to make a more general recommendation. So Kim, I don't know if you have more insight there.
I think the only thing I would add is they still are waiting for the data to come in from Moderna. And so a lot of the discussion is based around the Pfizer vaccine still and booster shots for Pfizer. And ideally, they would like to be able to make some kind of conclusions, draw conclusions about the Moderna vaccine as well. But they're still kind of limited in terms of the data that they've received so far.
And then Jonathan writes that he had a breakthrough mild COVID case in June and a booster shot 2 weeks ago, and wants to know if there are any stats for second breakthrough new infections, as there have been several negative tests.
You know, Kim, I haven't seen any data on second breakthroughs yet, just because the additional vaccine dose is so new. Kim, have you heard anything?
I have not either, Dr. Leung.
And then there's another question from Deanne about our stockpile of vaccines, and is it still good? Are they expiring, or how do we stand with those?
Kim, I don't know if it would be correct to say yes and yes.
Yes, I think, yes.
So there is a good stockpile. There is vaccine that is, getting towards the end of the shelf life. And I think people are also getting more comfortable that the vaccine probably can sit a longer time without going bad. So we are sort of getting, more and more news that, oh, by the way, you can keep using this a little past the shelf life expiration date.
Yeah, I think the only thing I would add to that is we are, with vaccine, as with everything else in this pandemic, learning as we go. So the shelf life will be marked on the vaccine, and then through additional testing, the shelf life has been extended, particularly on the Johnson & Johnson vaccine, because as they're testing it, they're finding that it is still as good as it was earlier. So there's a little bit of learning as we go in terms of how long the vaccines are good for. But as of right now, we do have more than enough supply to meet the demand. And that's something that we're being cautiously optimistic about in terms of boosters, and depending on how those are rolled out, how the supply may be impacted. So if they are in fact rolled out in kind of a methodical way, similar to what Dr. Leung described, where it may be certain groups at first, then I think the supply can keep up with demand. So something we'll watch.
And then another vaccine question, there were other vaccine candidates that were in research that we haven't heard much about. I know the Novavax vaccine was one that was studied locally, and some of us were in those trials. Any word on that or other vaccine candidates that might still get approved?
Kim, I don't know if you have other insight, but to me, it's has seemed remarkably quiet regarding other potential vaccine candidates.
I would agree.
And what's the status of the monoclonal antibodies being used for treatment? And then you mentioned earlier there was some concern that the new variants might not.
Could you repeat the question? Can you?
Sure. I'm sorry, Jerry. I'm asking about the monoclonal antibodies that are used for treatments, and if those are still effective, and if there's concern that the new variants might not work on those, or that the therapy might not work on new variants.
Thank you.
So the monoclonal antibody infusion, which is a mouthful, is, first of all, it's basically a man-made version of antibody. Natural antibodies that your body creates in reaction to an infection with COVID. This is made in the lab, and we try to reproduce artificial antibody. It does look like it works very well. And the trick is you have to use it within a certain amount of time, typically within 10 days. So you have to diagnose people. People have to get tested early on. And then, the main benefit is in people who tend to be at higher risk for complications. So maybe someone who has some trouble breathing, someone who is not quite so sick to be in the hospital on oxygen, but who, again, it has some conditions that may raise their risk. And so for those individuals, especially, we believe that the monoclonal antibody infusion, is beneficial and could potentially help keep them out of the hospital.
Great, thank you. And then a corollary to that is, what about survivor plasma? We're not hearing much about that anymore. Early on, with a lot of talk about that. Is it no longer considered effective, or other treatments are better?
And I apologize, I missed part of that question, the corollary.
About the survivor plasma.
Oh,
plasma from people who've survived.
yeah. So the initial research on plasma was very promising, but supply is very challenging. So it's probably much easier to get supply for the monoclonal antibody infusion than the plasma. And Kim, I don't know if you have anything to add there.
No, I think you got it, Dr. Leung.
And then there's a question about early on in the pandemic, we were told about the logistics for the various vaccine candidates, because some of them had to be in special ultra cold freezers and so forth. It could only be, and only had a limited shelf life after that. Has any of that changed? You mentioned the J&J. What about the others that had the ultra cold, cold chain requirements like Pfizer and Moderna?
So without getting too much into the technical details, we've seen that with the additional vaccines and sort of the adjustments with the process for kind of distributing and storing vaccine, that it's gotten a little bit easier. But in general, the Pfizer vaccine still requires pretty cold temperatures and some special equipment. And that, of course, is on the flip side, one of the benefits of the Johnson & Johnson, which does not require the same level of cold storage. But it does seem like, as we've evolved throughout the pandemic, our ability to be able to store and distribute and kind of package the vaccine in a way that's sort of more practical has improved.
Great, thank you. And then kind of a follow-up to Jonathan's earlier question, or remarks about his breakthrough case of COVID after being vaccinated. He said his primary care provider was not interested in getting him the infusion within the window, and he had to advocate for and get another doctor because they had claimed that CDC did not mandate getting monoclonal antibodies. Has that changed, or is that kind of provider discretion? Or any thoughts on that?
Yeah. So, first of all, we believe that the more information that everybody has regarding whether it's treatment or prevention, the better for everybody. And definitely, the knowledge base about COVID and vaccination and treatment is evolving every day. So, if you're hearing something that doesn't sound quite right, or you've heard about something that's new, we definitely encourage you to talk to additional resources or experts. But first, starting with your doctor, and if you're not sure, talk with another doctor or get another expert opinion. Many of the recommendations and guidelines that we have are fairly straightforward, but there's always some room for clinical judgment. And that's where, a doctor who knows you well may say, it looks like you don't fit, from these first three criteria, but I know you, and I know the other things that you have. And because of that, I think you should, get it, or you shouldn't get it. So that's a really good question, but I think that's balancing, the practical scientific criteria as well as sort of the art of medicine.
Thank you. And then there's a really good question about vaccination disparities with respect to different ethnicities and demographics. Can you speak on that a little bit?
You want me to start there, Dr. Leung?
That would be great, Kim.
Okay. So I think that in this group, we've talked before about some of the partnerships we have with community-based organizations and faith-based organizations. And so while those partnerships were incredibly important during testing and doing education and outreach, we're finding them to be even more critical as we're trying to I guess, convince people to, or nudge them to get vaccinated. And so we actually take a look at the data on a regular basis. We're looking at where we have our lowest vaccination rates by age, by race, ethnicity, by geography. And then we're partnering with those CBOs to go out and do really boots on the ground community work. And so we're going to churches. You may have seen in the news recently, we've done a vaccination campaign with haircuts. So it's a Trim the Hesitancy campaign. And so we have people that are giving vaccines in salons and in barbershops, because that's where in some communities, those are the trusted sources of information. And so really trying to meet people where they are in the community and get to the root of the hesitation and address that hesitation. So it remains a challenge, and our numbers are not as great as we want them to be. We see that our lowest vaccination rates are among 18 to 49-year-olds. That tends to be the population that thinks they're probably the most invincible. We know that we have lower vaccination rates among our African-American populations, although I'm happy to say that those numbers are going up. We have an amazing group with partnerships with Building Resilient Communities, the Black Chamber of Commerce, and some others that have really been doing a lot of outreach to those communities. So it remains a real concern, but it's something that we are hyper aware of and working really hard to address. And we don't have all the answers. So if anybody has any ideas, please let us know.
Great, thank you. And somebody asked about, is there any evidence that the vaccine has serious side effects? And if so, for whom?
And
Yeah. So in terms of serious side effects, which, we would put in a category that's very different than having fever or headache or soreness, during the first 1 or 2 days following the vaccine, the rate of serious side effects is very, very low. It looks like it's less than 1%. And we've been tracking, the side effects very, very closely, probably more closely with this vaccine than any vaccine in history. The very rare but serious side effects, we've seen some serious blood clots with the Johnson & Johnson. We've seen some myocarditis, which just means inflammation of the heart wall in some specific younger groups. But again, all of this is at a very low rate. And when you compare it with the risk that's associated with getting COVID, we believe the benefit of the vaccine far outweighs the risk. And if you remember one of the slides that Kim went over earlier, for people who are not vaccinated, out of that 800 and 1,000, some people who are unvaccinated, and where we saw over 100,000 cases of COVID, that's about 1 in 8 people in Riverside County who are unvaccinated who actually developed COVID. And so you really need to compare that type of risk with the risk of side effects that you could get with a vaccine.
Thank you. And then someone else asks, what is meant by untreated HIV infection as a marker for immunosuppression?
So someone who either is not taking any antiretroviral therapy or for their counts. And so, assuming that someone's counts are low, or that they've been off or have never started antiretroviral therapy, that's probably my guess for what most people would consider to be untreated.
Thank you. So that's it for the questions in the chat. Does anybody else have a question they'd like to ask? In person, if you could raise your hand either like that, or put your little hand up, or type something in the chat.
Jeff, it's Carlos.
Yeah.
I have a question, Dr. Kim and Dr. Geoffrey. How are you guys keeping track of patients that actually buy those at-home kits, the Abbott kits or whatever kit, and test at home, and then they test positive? And so do you guys keep track of those cases?
That is,
Kim, do you want to start with that?
Sure, that's a great question. And first, I just have to clarify, I am not a doctor. So Dr. Leung is the doctor. So that's why he takes all of the medical stuff. So unfortunately, when people test at home and they test positive, there is no automatic notification to the public health department. So the only way that we would learn of those cases would be if the individual called us and sought out some type of guidance about what they should do with a positive test.
Okay.
Great, thank you. Yeah, lots of gaps in the surveillance, as we're seeing.
Yes. Yes.
Kind of frustrating. Anyone else? Going once, going twice? If not, thank you so much, Ms. Saruwatari and Dr. Leung, for joining us. We really appreciate getting these updates from you periodically. It's an evolving situation, as you know, so it's great to have you come and share with us. So thank you so much for taking time out.
good night.
Thank you for having us.
Thank
We
you.
appreciate the time.
Thank you.
Have a great evening. So we have a few updates before we close. So from Palm Tree, Jasmine Parkinson and Dr. Martinez have a study they wanted to briefly tell us about.
Yeah, thank you, Jeff. I'm Jasmine. I currently lead the infectious diseases department with Dr. Carlos Martinez here at Palm Tree. And I just wanted to mention a few studies for anyone who may be interested. We do have our Illuminate clinical trial for our HIV population who is heavily treatment experienced and have exhausted all or nearly all antiretroviral options. So if they're currently failing their antiretroviral regimen and have multiple class resistance, we do have a treatment with doravirine and islatravir that could potentially be an ideal treatment for this population due to its potent antiretroviral activity by its multiple mechanisms of action. And we also do have a gonorrhea study. Anyone who is 12 years or older and has a suspected infection. We do work with Dr. Phyllis Ritchie, and she just opened her free STI treatment, test and treatment clinic, and operates out of our site as well. So anyone who wants to get tested for free, she not only does STI testing, but does PrEP treatment as well. So I can put my information here in the chat if anyone has any further questions or wants to get any information.
Great, thank you, Jasmine. And I did put in the website for Palm Tree Clinical for the clinical studies, so they can check all those out. Thank you. So next up is you've heard us talk about the Aging Positively Reunion Project event coming up on September 18th, HIV Aging Awareness Day. And so this is because of COVID last year, RPS was able to do its annual reunion project, which would be the 6th year actually. So we decided to join forces with Desert AIDS Project that has been doing its Aging Positively Conference in combination with a bunch of community partners like the Center, Our Health, Jewish Family Service, Let's Kick Ass, and others. So it's a real community collaboration. And it's going to be September 18th on a Saturday from 9 to 2 p.m. It won't take up your entire day, but we have a great program, including our keynote speaker, who is Andy Bell from the 80s disco pop group Erasure that many of us may remember from the dance floor way back when we still danced. And so he's been an advocate for LGBT rights and HIV, and it was an amazing story, and we're really looking forward to him. Also, we have someone named Carl Schmidt, who's a reporter for ABC in LA, and he's also positive and came out recently about his HIV diagnosis, and has become a very vocal advocate for that. And we'll talk about what it's like working in journalism and what he sees from both sides of the camera, so to speak, as someone living with HIV. We're really excited, and a bunch of other really great programs as well. So we encourage you to attend. I just posted in the chat the blurb and the link to the Eventbrite. So we encourage you to go register. And if you don't register beforehand, you can still show up the day of. We're not cutting it off, and of course it's free. But this way we have a sense of how many people will be coming. So please share this widely. It's going to be on Zoom because of COVID. So share it with friends anywhere and everywhere. So if you're up in Seattle or someplace like that, you can still participate and share that with your friends. And we look forward to seeing you there. So, yeah. But I heard a question. And what else? AIDS Walk. Heart PS is going to have a team this year, as we do every year. So please feel free to check out our page. I think Lee Franklin will put that up for us. Can't do too many things at once. And but October 30th is a Saturday, and it's AIDS Walk. It's the week before PS Pride, and it's going to be in person again this year. Last year they did it virtually, so they asked teams to go out and take pictures and document their activities online. But they're going to have the full event at Ruth Hardy Park, as in past years, Park will have a booth there, so come stop by, and we hope to see you there. So come out and get the chance to socialize in the great outdoors, and you know, relatively safely. So we encourage people to come out. So anybody else have anything they wanted to share, any announcements they'd like to make before we give you back the rest of your evening? Seeing none, we will thank you for joining us. It's great to have everybody back after the summer. And as of now, we're going to be virtual like this for the foreseeable future. Our home at the Desert Regional Hospital in the Sinatra Auditorium there is still not available and won't be for some time. So we are going to be doing this you know, for the foreseeable future. So stay tuned, check your email, and if you have any questions or comments or suggestions for other programs or speakers, please reach out and let us know. So thanks everyone for coming out tonight. Have a lovely evening, and we'll see you again next week.
See you.